Okay, so welcome everybody. It is Friday, May 31st. It is 2024. We are here for another Florida EMS webinar. This is going to be a great one. We have two great speakers, and we're going to be talking about a very hot topic with backed by some powerful data. So we have Dr. Juan Duchesne. He's a trauma surgeon out of Tulane Medical. He's a medical director for the TICU, and he's very well published. And we're so proud to have him on the team as we move towards whole blood penetration throughout the United States. And then also joining him today will be Dr. Mark Piehl, a very close friend, someone who has done quite a number of things, both on the clinical side, and he's helped us with the LifeFlow device, which he's the inventor of, that we use for whole blood and for fluids in the field. So, gentlemen, without any further ado, take it away. Juan, I know you're going to start, and then Mark's going to continue. Welcome
Peter,
to
let
the
me just give
show.
the disclaimer that though I have a relationship with 410 Medical, our devices used in these studies, there's no funding provided. These were all done out of Tulane and without any company funding. So just wanted to
That's good.
give that
That's good to
disclaimer.
know that.
And one more title that you left out, Peter, for Juan, is he's now a medical director for New Orleans EMS. So
Yes.
yes.
All right. Trauma surgeon
I
in EMS. We love that.
I help them. That's how I call it. I just help them. All right.
Awesome.
So thank you everybody for your attention. We're going to be talking about moving the pendulum of resuscitation, and I can talk for 4 hours about this, but what I decided to do is to basically put together what our journey has been and what is looking forward of what is going to basically progress to. So how all this started, because I think everybody now have seen Spark, and people ask, why Spark? What is Spark? And it all started during the COVID time, when basically a lot of trauma surgeons decided to figure out why we still have patients arriving to the emergency department with injuries that could easily be basically resuscitated effectively in the pre-hospital setting. And then when the patient arrived to the hospital, those patients would fare better. So we put this paper together, was published in Shock, which is basically called Selective Pre-Hospital Advanced Resuscitative Care, SPARC, Strategy to Prevent Pre-Hospital Death from Non-Compressible Torso Hemorrhage. So basically what this paper is, which I definitely recommend anyone that is interested in pre-hospital care to take a look at it. If you need a reprint, just fire me an email. I'll be more happy to send it. And what it is basically that it says that those individuals on the scene that are taking care of the patients are the ones that can make a difference in patients' outcome. So we need to empower them with procedures, technology, and all the equipment necessary to effectively resuscitate the patient, not with crystalloids, but with blood, plasma, whatever you can give that the patient is bleeding. So, and other interventions to stop the hemorrhage. So from scoop and run, we basically start talking more about scoop and control, which basically encompass control of hemorrhage / resuscitation. So Daniel Remick is basically the senior editor of the journal, and he basically asked us, he was the one that gave us the thumbs up. We liked your paper, we're going to publish it. And then he stayed in touch with me about how much this paper is being cited. So it's a hot topic out there. And I think that people are finally getting a grasp of it. So I surrounded myself with an amazing group of people that are so much smarter than me, that are basically in this meeting today. And we put something together. We call this the Spark Academy, which basically is education about resuscitation and advanced procedures on the field, on how we can provide this education to the pre-hospital people. So what takes us there? I'm going to talk quickly about our experience and our studies. The first study that came out from our institution was the faster refill in an urban setting, where basically this is the first study that actually looked at a fast pace, urban setting, what is the impact of giving blood? And first of all, is it feasible? And what was interesting is that when we compared the patients that receive what we define as the ARC bundle, Advanced Resuscitative Care Bundle, which consisted of 2 grams of calcium, 2 of packed red blood cells, and 2 of TXA. When we compared those to a historical control, it was interesting to notice that actually the shock index was effectively lower than the patients that received crystalloids. The injury severity score was basically the same. And we're talking about specifically penetrating trauma. These people are dying en route. The 24-hour mortality from 19% dropped down to 16%. And the overall in-hospital mortality from 23% to 10%. So this was the first study that was like a slap in the face, especially to me, to us, because we were in shock that, wait, everybody was saying that this is a waste of time. So maybe it was a waste of time because the patients that were receiving the blood products were not getting that in a very fast pace. And I think that basically, thanks to technology with Mark, rapid handheld infuser, and having basically the blood, the tranexamic acid, the calcium, it created a huge impact. And what is interesting is that, and I will talk about this later, we are not the only people doing this. There's other institutions that are actually seeing the same mortality, and that's what's really interesting. So more to come on the multi-institutional approach. But in summary, for this specific study that was published in JTACS in January, the ARC bundle convey a survival benefit. And what was interesting is that dogma of hitting on the gas, this is all you need, no difference. No difference. Now, we're going to talk about timing in the very last study that we did, but just put that in your brain. Pre-hospital time, pressing on the gas, fast, was not protective or increased survival.
Hey,
so,
Juan, can I throw in a point? Just you may not highlight this yet, but note the endotracheal intubation stats, which is totally fascinating. Your teams found that they basically had to intubate no one in the blood phase. They resuscitated them. The patients woke up. They didn't need pre-hospital airway management, which I think is obviously the mortality is the key thing, but this is a totally fascinating finding.
Yeah, and that's, let me tell you a quick tease. The PACT study from Lights Network have seen a decrease in intubation in the pre-hospital setting. And I don't know if they're going to be mad at us, but something is happening right now with pre-hospital intubation is going down dramatically. So that's another food for thoughts, but great point. So that takes us to the second study that we put together, the ABCDE, where basically everybody knows that that's what ATLS has been pushing over the years. Now, we're not going to get into the details of how that worked out, but basically there was no good level 1 scientific evidence to just say that for trauma hemorrhage, ABCDE is the way to go. So basically, last year, we were invited in the spring COT to discuss the algorithm. And what was interesting is that in that same meeting, the director of the committee of ATLS expressed the new algorithm, or the new mnemonic, XABCDEF, where X stands for hemorrhage control circulation. So they didn't want to call it CAB. That's their problem. They put a stupid X in the front. But it works for us. It still works for us, right? So we play with whatever mnemonics you want to put on. And for anyone that is interested, right on the bottom, that is the link. Take a picture. That is the link for the whole presentation. It's a very good presentation from the ATLS chair. So we decided to look specifically and be the first ones to spearhead this. Our program, after 4 years in evolution, we finally started in 2021. And basically with this ARC mode of resuscitation, the goal was to prioritize circulation. And basically, this is a quick video.
You want me to give him this? TXA's in.
Yes, and inside.
So this is just the amazing Neolin CMS team, medics and paramedics, basically giving blood, calcium, and TXA. So we decided to look at that experience where basically circulation was actually prioritized prior to intubating the obtunded patient after penetrating trauma, hemorrhagic shock penetrating trauma. And the algorithm was very simple. Basically, for pre-hospital ARC bundle, it was triggered by low systolic in the 70s or systolic less than 90 with a heart rate greater than 110. And once that was checked, basically the sprint truck, which carries the blood, will basically have ready the blood, 2 units of blood, 2 of TXA, and 2 of calcium. And that most of the times, I would say 90% of the times, has been given prior to patients' arrival to the hospital. So this is the heat map of the only CMS pickups for transfusion. And as you can see, the X is where our trauma center is. And then the rest of the heat map, you can see where we have the other patients. So we have up to date, and I bet that number have increased because this presentation was done a couple of weeks ago. And I believe I reviewed at least 5 to 7 new blood given pre-hospital. So I bet you that the team is very close to 260 right now. And then from there, we basically decided to do the study. And the study was to compare what happened when circulation was achieved first versus the typical airway, breathing, and circulation. So we look at 62 patients in the ARC bundle circulation first, or XABC, versus the ABC. And what was interesting is that the in-hospital mortality, all right, was 13% for the patients that circulation was achieved first prior to intubation, versus in the typical routine ABC, where intubation was performed first, the mortality was 47%. You can see that that is problematic. That is huge. And when I first looked at these numbers, I was like, there's no way on earth this is happening. And it was very disturbing because if you think about this, what is happening is that this group of patients, if you think about this, we're basically creating our own problem, meaning increasing the mortality by basically decreasing the preload with intubation, and then basically with paralytics as well, with compliance. So a lot of things can be done better. And I think that this study is sending that signal that XABC is here to stay. So in conclusion, in pre-hospital with basically hypotensive patient after penetrating injury, this type of care where circulation is first prior to intubation, it definitely improved patients' outcomes. And last I have here is the last paper that we put together entitled Every Minute Matters, Improving Outcomes for Penetrating Trauma Through Pre-Hospital Advanced Resuscitative Care. Now, this was a very interesting study. And everybody, the reason why we did this study is because we keep hearing and hearing and hearing. It doesn't matter. Bring the patient to us. We'll give the blood here. So we say, okay, if that's the case, I believe we have data to say that that kind of thinking is wrong. So what we decided to do was to compare for patients that receive pre-hospital blood versus the controls, the ones that receive blood once they arrive to the hospital. We compared the outcomes and mortality. And what was very interesting, and what we identified in this study, is that pre-hospital blood started 8 minutes after patient contact when compared to that received blood in the hospital arena 26 minutes later. And that's huge. Just think about the physiology, right? I mean, we're talking about close to a lot of like 19 minutes, 20 minutes for these patients to receive the first unit of blood when you're in full-blown exsanguination. And what we basically identified in a quick summary is that there basically, there was a, compared to patients who first received blood after hospital arrival with blood products, when blood products was started 19 minutes earlier after initiation of pre-hospital blood program. And there was definitely a survival for early pre-hospital blood use was demonstrated with 11% mortality increase for each minute delay. And that's huge, okay? So I think we're putting the puzzle together and it's making more sense and more sense. And there's so much more to come. So I just wanted to put now what has been presented, what has been published. That being said, we did our first Spark Academy in March 12, 2024. And it was simply amazing. We had more than 100 plus people, first responders in that meeting. And this is a quick video of what Sparks looks like.
We're already like, hey, start blood. I'm going to keep working this massive hemorrhage.
So an amazing group of first responders and team members have basically joined the cause, and it's been a blessing to work hand in hand with them. And we are ready for our second Spark Academy coming up in June 11, 2024. So at this point, I'm going to stop just for more questions. But before I do that, I wanted to bring to the attention that our Spark registry is increasing. We have 497 patients in the data right now. And the data that we're getting out is sending some heavy signals. I'm not going to tell you what, but it's sending some heavy signals. And let me tell you, this data has from crystalloids only to packed red blood cells to whole blood to plasma, cold, warm, you name it. This is going to be a beast. And the way it's molding out is going to be simply amazing when we start putting this data outside. So thank you so much. I'll be now open for question. And Mark, feel free to add more to the presentation.
No, it was awesome, Juan. Let's just take questions.
Yeah. So Mark, I know you have slides, right? But
no, I think Juan's covered it all. Let's just let people ask questions.
Okay. So let's ask this question first then. So the Tulane registry is now going to be the Spark registry. I love that. And we have people on this call, David Long, I see his face, who is giving a lot of blood. Are we getting everybody in that we can to the registry? Because I think that's going to be the key point here.
Yeah, I can tell you, it's been interesting to see the evolution from just Tulane to now up to 9 centers. I think over time we're going to get more and more people. I think the limiting factor is who's going to put the data in. Like for example, we had an explosion coming from the Rockies and an explosion coming from Florida. So it's once we identify who's going to be that designated person, I think we're going to keep populating the data.
Okay. All right. Excellent. Let's bring in questions. We have a lot of people on the call today. I see Candace is coming in now. What do you say to the naysayers, right? So, and I'm just I think we have to mention this because there's the refill trial that was published out of the UK that shows pre-hospital blood doesn't work. We have our friends and colleagues in San Antonio who are showing something different with respect to penetrating trauma than you're showing in New Orleans and that we're showing here in South Florida. And yeah, I see Matt Levy on the line. I would love to hear from him too. But what do you say to the people who still are not believers yet, based on what you just presented and what's been published in the past?
Yeah, I think that it's crucial to understand that what may work for us, it may not work somewhere else, right? I think the population that we are taking care of penetrating at a very fast-paced environment, that might be very different from many other centers. Our transport time, we're talking about 11 to 12 minutes on average. And that I think will be hard to replicate in many other trauma centers. I believe that, I don't know if we have people from Grady, but I believe their experience has been very similar to ours with the fast transport time. So I think that everything needs to be basically molded to what you have. If your transport time is going to be longer, you may need to think different. You may need to think about other modalities of resuscitation, not only just blood, but maybe whole blood, start adding some PCC, so much more to come. And I believe that we don't have the answer to all those modalities out there.
And I know Mark, he's hesitant to talk about this, but I will because I can. But I do believe that the rapid infusion, because the folks in San Antonio are not doing that. What are your thoughts about the rapid infusion versus the non-rapid infusion of blood? Because I think that's an important factor.
Yeah. No, thank you for bringing that to my attention. I think that that was my priority when we started the program. I was I don't want to say disappointed at the combat trial, because it was kind of like expected, their outcomes, based on no way to infuse this in a timely manner. So having the product in the unit is not going to save lives. End of story. Is how fast you get that inside the intravasculature of the patient. And you need to figure out that. I mean, I've been blessed that through social interaction, I met Mark and we put the puzzle together and it is working perfect. So, I think that that's something that people need to take into consideration. Our New Orleans EMS has been able to put 500 cc's of blood within a very short 10-minute transport time. So this makes a big difference.
Peter, the other thing is to contrast the refill trial. And if you'll note, Juan's first study was titled Faster Refill, kind of a play on the UK refill trial, where they took 90 minutes of pre-hospital time to give their couple of units of blood, 90 minutes, and didn't show a difference between saline and blood. Whereas in Juan's team, the New Orleans team, actually, I think Juan, in that first study, the average transport was 8 minutes. So 8 on the scene, 8 in transport. And maybe you're showing that's tightening up since then. But a lot of interventions, effective shock resuscitation interventions provided in a short window. And I think that's probably the key to the survival benefit and the reduction in pre-hospital airway management that they're seeing.
Yeah, the refill study is definitely different, and different way of resuscitation.
So we have other questions coming in. Let me start with Dr. Mohammed Daya. Any data on blunt trauma patients?
Right now, that answer is going to come from the multi-institutional study, because most of our patients, 90% of them are penetrating, if not higher. But from the MIT that we have, the data collection in Spark, we have quite a bit of blunt. So I think it's going to be interesting to see the impact of TBI, mild, moderate, severe, and how that impacts overall outcomes in the long term. So more to come.
Let me bring in Chief Coyle.
I was going to say, Mo has to understand that there's the traffic is so bad in New Orleans that it's like a parking lot. It's hard to get killed there. So,
and Chief Coyle, can you pop in real quick and talk about our blunt trauma outcomes? I know that you just sent me our spreadsheet today. I can pull it up if you need me to, but you want to talk about our mechanism of injury data?
Sure. And as always, what an honor to be on here. And Dr. Duchesne and Dr. Piehl, amazing work as always. It's an honor to work with both of you on the Spark Academy. But it was crazy. I looked at our data last night because I just got the dashboard up, and we had 49 blunt cases that are related to motor vehicle collisions. We had a couple in the fall category, and essentially what we're showing survivability. Basically we determine the outcomes if the patient walks out of the hospital. So we look at shock index before, and then we look at shock index after the administration, and then we look out, does the patient make it out of the hospital? We were showing, I believe, I can't see the number because I'm on my cell phone, but I believe it's like 80% survivability, and we're showing 88 in the penetrating world. So I was shocked by MVCs to have almost 50 cases and show 80% survivability. I don't know what that mirrors across the country and what other people are seeing, but to me that was a pretty significant number.
That's awesome.
Yeah,
Hey, Chief Coyle,
did you have
a comparison, like even historically speaking?
No, I don't, but we have enough cases that didn't get blood, like if we retrospectively look back, where we could probably easily make that comparison. So I would have never thought I would have saw 80% survivability with a blunt force trauma secondary to an MVC.
Yeah. But with the proviso that they had shock indices that were low, or high indices, right?
Correct.
Right, yeah.
Correct.
Yeah.
So I want to bring in a couple of people. Chief Cardona asked a question. I'm going to table that only because that's what we talk about heavily at the Spark Academy coming up in June, and it's probably a longer answer. But I want to bring in two people. So David Long, out of Tidewater EMS in Virginia, has done incredible work. Has put blood across a huge portion of that region. So David, please make some comments, and then I'm going to go to Matt Levy from Hopkins after that.
Sure, Doc. I'm happy to. And I think, like Chief Coyle said, certainly an honor and a pleasure to be here. And I appreciate all the trailblazing that you all have done, and we've certainly learned from, and just essentially replicated and attempted to look at what was unique in our region and figure out different ways to attempt to move the needle. For us, we've followed the New Orleans model that Dr. Duchesne, talked about. For us, our advances resuscitative care bundle is just a little bit different. We do 2 grams of TXA, 1 unit of whole blood, and then we do a gram of calcium gluconate. And then with it, we have submitted an IRB. We have the review on June the 6th. And with that, we're looking retrospectively at 3 years worth of data in regards to what calcium levels are, in our trauma patients or those suffering hemorrhagic shock, to be fair, because we're also looking at our medical cases. But what we've already seen, just starting to pull the data, anticipation that the IRB will be approved and things of that nature, is we're seeing ionized calcium levels at about 0.87 to 1, which we know is significantly hypocalcemic. And what we're interested in, and we will be submitting a follow-on prospective study to be looking at the same data elements, except now looking forward with us administering calcium to determine what does 1 gram of calcium gluconate do to raising calcium levels, and then we can essentially, finesse our way into what we believe is the most appropriate dosing, of calcium gluconate. So we were a little bit more conservative than using calcium chloride like it's being done down in New Orleans, but we've seen some significant impacts and results, doing this. So Dr. Piehl was gracious and provided me, with a lot of information that he used for the Spark Academy, that we essentially created our version of it here. We've administered across our 4 jurisdictions that are involved in the blood program, and we've seen a significant reduction in the number of intubations occurring, which is also impacting our survivability to discharge. And I think the surprising thing for our folks has been, in 2 instances, we've significantly impacted patients transfusing blood, and only to have a helicopter EMS crew and a emergency department essentially move immediately to RSI and trying to intubate patients that weren't, and both patients immediately went into cardiac arrest. So from an EMS provider perspective, their eyes are completely open to, that hemodynamic stability and holding off on, which is spark conversations in our region about what the future may look like in regards to bypassing the emergency department and going straight to the OR. So those are some interesting conversations that are taking place. But we are working desperately to get into the registry. We're having a problem with one of our healthcare systems, so we're trying to connect them to Madonna, and hopefully that will resolve some angst with doing that. But otherwise, appreciate everything that you guys continue to do, and we look at everything that you guys publish and or communicate. So thank you very much.
David,
I know
could
Juan.
you?
I know.
Go
Wait,
ahead,
hold on. I know Juan's got to jump. Juan, you want to say some final words before you go? I know you got to jump to a meeting.
Oh yeah, I just want to say, David, you have the best people next to you, Madonna. She's amazing. She's gonna fix problems for you. But I want to say quickly, David, I urge you to look at Herman Duke's Trauma Center in Houston. They do have already an established protocol, validated, on how to activate from the scene. Take a look. Take a look at that protocol, because that may actually empower more your system. All right, team.
Awesome.
Thank you so much. Have a great weekend. Looking forward to see most of you at Spark.
Awesome. Thanks, Juan. Let's go to Mark and then to Matt. Go ahead, Mark.
Just quickly, David, I wanted you to address those survivors from traumatic arrest, which is amazing. And two, the ICAL numbers you mentioned, were those before giving calcium? That's just someone who came in hemorrhagic shock and you checked the calcium? Just to confirm that.
Yeah. So those were numbers without calcium. So
Okay.
So that's coming in, and one of the things that we've identified and why we've, in our data collection tool, we recognize that we may have a patient that comes in trauma-wise that doesn't receive whole blood, that we want to get that information on. A patient that does receive whole blood that may not receive any calcium supplementation. So we know that there's potential for 3 distinct groups of folks, and how we have to look at those numbers and parameters.
Yeah, that's great. And we're looking forward to that data. Thank you so much for getting that done. And then last but not least, Matt Levy from Hopkins. You guys are up and running. Give us some of your insight and your wisdom.
Hey, everybody. Good morning. I'll be very brief because I know the other calls are starting soon. Sorry for joining late. Actually, one of my senior residents was presenting about blood. So a couple of quick things. I would echo the comment. I think the devil's in the details here, and I think the time piece is really a big thing. Increasingly, when we speak about blood and teach about blood, yeah, we talk about a bag of red stuff, but we're really talking about a bag of time. Right. And we're buying time back. This is just a temporizing measure to get definitive hemorrhage control, source control, while we effectuate a comprehensive resuscitation, be that in the OR, in the ED, wherever it needs to be in the field. And to that end, I think that the time does matter, the details matter. So I would echo those comments strongly, at least observationally, that's our experience. We have made the commitment that once we pre-hospitally say go for blood, that we want it in within 5 minutes, right? And so how that happens, it depends upon the circumstances, but we all recognize the priority there. The only other piece, Peter, I would add, and I would say is we're dealing with an intrinsically sick population. And yes, obviously we all care about the definitive outcome of walking out of the hospital alive. But they have to get to the hospital alive to walk out of the hospital alive, and they have to make it to the OR suite or the angio suite and every place in between. So while I am the biggest patient-centered advocate for outcomes-based research, I would also say that we have to not ignore the interval fractile metrics as well. They're super important here along the way. I'll turn it back to you. Over. Great to see everybody.
Perfect. And that's why we all have to work together and pool our data, pool our knowledge. A lot of the stuff we're doing, we're just learning from other people. So if you're out here in the audience today and you're thinking about it, you haven't done it yet, you started and you need help, we're all part of this one big group. We have a Dropbox folder that I can share with everybody that's got tons and tons of protocol data, whatever you need. But let's work together and make this happen. And if you can get your data into the Spark registry, that's just going to help the next person get going. So Mark, let me give you the last word. Take us out. And again, thanks for all that you do, your innovation, your clinical work, your speaking, everything you're doing. Thank you so much. Take us out. Give us the last word.
Well, thank you for highlighting this topic. And I just push the credit back to Juan and New Orleans team, who have really been the first folks to innovate in the way they have and publish the first data to show that blood in ground EMS in urban environments reduces mortality. That's never been shown. I think it's a dramatic finding. Minutes do matter, and they're proving it. So I can't wait to see the outcomes of this larger multi-center trial that should be coming soon. So thanks, Peter, for having me.
Thanks, Mark. And you have published a lot. We've put some things in publication. Matt just put his publication in the chat. So if you're going to do this stuff, folks, you got to publish it. There's no reason not to. Connect with us if you need help with that, or just send your data to Juan and he'll publish it. So with that being said, thank you guys. Have a great Friday. Enjoy the weekend. And there's a link here in the chat to get to Dr. Pepe's webinar. I'll put it in there again. And we'll see you guys on the other side.
Thanks,
Thanks
Peter.
so much, everybody. You got it.
Bye.
Thanks, Mark.